timer, and here is your question. Right, so if you have read and understood, considering the surgical and optimization, kindly tell me,
Yes, ma'am.
what is the image you are looking at?
Number A is
Just tell me the image. It's the, which view of what?
okay, ma'am.
Right side or left side? Yes, please.
It's a ma'am. It's a cubital of fossa of the right hand of the
Okay.
right side.
All right. Okay. Then, can you please tell me what are the boundaries of the cubital fossa? First of all.
Okay, the boundaries of cubital fossa, there are lateral boundary formed by brachioradialis muscle, medially by pronatoteres, and floor by brachialis.
And roof?
Roof by skin and superficial fascia.
Okay, good. Can you please now identify the structures from A to G? H, sorry.
Number A is
It's
number
here.
A is number A is
median.
Okay.
Median
Okay,
nerve.
if you can imagine, medial is here and lateral is here. Now close your eyes and imagine what would be the structures here in the cubital fossa. Okay, then B, please. It's a muscle.
It's a medial side. It's a pronatoteres muscle.
Okay, and C,
number
please.
C is number branch of brachial. It's radial artery, and number D number D is can I say number E? E
All
is
right,
brachial
okay.
artery.
Okay, and here it's a vein, it's blue. So what can you imagine? Which blue vessel? And it's kind of superficial, you know. See?
It's a basal, it's a cephalic vein.
All right, we'll get back to that. Okay, and F, please.
And number F is medial. Number F is another artery.
All right, and G and H. G
number
is
G is brachioradialis, and H is ulnar artery, radial artery.
Okay, can you please tell me, if you have to take a blood from the antecubital fossa, which vessel would you prick and how would you do it?
The median cubital
Vein, okay. And then, can you tell the relation of it? Yes, how would you feel?
Medial cubital vein, there is laterally it's a there is a cephalic vein, and medially there is a basilic vein.
Okay. What more can you tell me about yes, how elbow joint is formed? Can you please tell me? What are the bones which are involved in the formation of elbow joint?
Yes, ma'am. It's by capitulum of the humerus and radial head,
Yes.
and trochlea of the humerus and trochlear notch of the ulna,
Yes.
and olecranon of the ulna and olecranon fossa of the humerus.
Okay. If you can tell me origin and insertion of this muscle G.
It's brachioradial, brachioradialis.
Is origin and insertion.
Origin from, sorry ma'am.
Okay. Can you tell me?
Origin, lateral supondylar humerus, and insertion distal radius.
Okay. Can you tell me what type of joint is elbow joint and what are the movements which are possible at elbow joint?
It's a hinge joint,
Okay.
synovial hinge joint.
Yes. And what are the movements which are possible?
Movements are flexion and extension, and abduction and adduction.
Okay. Can you tell me what is the layer that protects the brachial artery when blood is drawn from the median cubital vein?
Skin, superficial fascia, and muscle, pronator teres muscle. Sorry, ma'am. Skin, superficial fascia.
Yes. Okay, can you please identify, this is picture A and this is picture B. If you can identify these structures or tell me how the muscles in the forearm are placed or arranged.
Yes, ma'am. In the forearm, there are some deep muscles and superficial muscles. And superficial muscles are brachioradialis and extensocarpidialis longus, extensocarpidialis brevis, and extensor digitorum and extensor digiti minimi.
Is
And
there
some
any?
deep muscles.
Yes. Yes.
Deep muscles are supinator, abductor pollicis longus, extensor pollicis brevis, and extensor pollicis longus.
Okay. All right. Can you please tell me, right, what are the muscles which are present in the bicipital or how, yeah, in the groove? Bicipital groove, or you can tell me the attachment of annular ligament?
Sorry, ma'am.
Okay, can you mention the flexors of the elbow? Which muscles are responsible for the flexion of the elbow joint?
Yes, ma'am. Flexion of the elbow joints are brachioradialis and brachioradialis, pronator teres, and flexor carpi ulnaris, and palmaris longus, and flexor carpi radialis.
Can you tell me the location or the relation of ulnar artery and ulnar nerve in the wrist? Which one is medial and which one is lateral?
Ulnar nerve situated in the medially, then ulnar artery.
Okay, it's opposite because nerves have to protect the vessels, so they are laterally. Okay. In the cubital fossa, if you can recall the relation of median nerve to brachial artery.
My median nerve, first of all, median nerve situated in the laterally, then anteriorly, and then medially to the brachial artery.
Okay, good. Okay, and these structures in the previous one, if we can quickly go. First of all, this is the left side, not the right side. Okay. How would you know? If you imagine this is medial, and if it's medial, so it is close to the body. So if you can imagine this, it's coming like this. So it's the left side, right? Left cubital fossa. And then if you point at A, so it's left median nerve. B is pronator teres muscle, left side. C is left ulnar artery. Left ulnar artery, and D is left cephalic vein. Okay, so from here it's going, it's superficial, it's blue. E is left brachial artery. F is left biceps tendon, and G is left brachioradialis muscle, and H is left radial artery. Right, and
Yes,
yeah.
ma'am.
Yes, and then this, the annular ligament, you can tell me how it wraps around the radial head and the neck and is attached to the margins of the radial notch of the ulna, and it allows the rotation of the radius above and virtually fixed ulna. So the movements which are present at elbow joint, it's flexion, extension, supination, pronation. And yeah, extension is only between 0 to 5 and the rest. So yeah, thank you.
Thank you, ma'am.
Started your timer, and here is your question. Right, so if you have read and understood, considering the history presentation, kindly begin.
I will wash my hand. Good morning, myself, Dr. Kuldeep. I am one of the surgical candidate. May I confirm your name and age of date of birth, please?
Name and age. Yes.
My name is Mr. X, 54 years old.
Good.
Okay, nice to meet you, sir. Today I was asked to ask you a few questions regarding. Are you okay with that?
Yes, please.
Sir, what you bring? How can I help you?
I'm having difficulty in swallowing food, doctor.
Oh, I'm so sorry, sir. Can you just tell me more about your difficulty in taking food, sir? How it started?
It started gradually, doctor. First, it was for solid material. Now I can't even drink water properly.
Sir, can you tell me how much duration of the symptoms? It has started for how long? Can you tell me?
Approximately 10 months, doctor.
Okay. Initially, sir, may I ask, is it initially to solid only or to liquid also?
Initially, it was for solid. Now for liquid also.
Okay. I'm very sorry, sir. Sir, do you feel any swallowing in your neck, sir? Any swelling or lump in your neck, sir?
No, I don't feel anything.
Sir, is there any condition which help you to reduce your difficulty or which stops your difficulty?
No, it is
Or
same.
any? Okay, sir. Anything else which increase your difficulty?
Before it was for solid, now for liquids also. So both I feel the same difficulty.
I'm very sorry, sir. Sir, have you noticed any episode of vomiting? After taking food, sir?
No, not typically as such.
Is there any, have you noticed any blood coming out of your food or any blood in your vomiting? If you have,
No.
sir, how was your appetite these days?
It has a reduced appetite. I'm not eating properly because of this problem.
Sir, have you noticed any weight loss, significant weight loss, like you have a loosening of your clothes and all?
Yes, I have lost weight.
Sir, can you tell me how much loss or over how much period?
Approx 5 to 6 kgs over 2 months, 2 to 3 months.
I'm very sorry, sir. Sir, have you noticed any burning sensation in your tummy or in your chest after taking food?
No,
Have you noticed any gargling or bad breath after taking food?
no, no.
Sir, have you noticed, as you told me, sir, difficulty more to the solid food, then initially to the solid food, then to liquid food, sir. Sir, have you noticed any lump in your throat or any bad breath recently, or you feel like something is stuck in your mouth, sir, while
No,
taking food?
Throat.
I don't feel.
Sir, have you noticed any difficulty in climbing stairs or going cycling, going upstairs, downstairs?
No, I haven't feel anything.
Sir, have you noticed any burning in eyes, dry eyes, or any cold hands and all?
No, doctor, nothing.
Sir, do you have any related history in your in the past, sir? Do you consult your GP for the same, sir, for any condition, known condition?
Previously, since few months ago, I was having this problem. I consulted GP. They told something is there in the food pipe. That's it.
Sir, are you taking any medication? Any
No,
regular
I'm not
medication?
taking anything. No, I'm not taking
Okay.
any medication.
Sir, according to what you think, sir, what you are having, what are your main concerns, sir?
Something related with food pipe, and my concern is the swallowing is difficult.
Sir, and what are your expectations from us, sir?
Please get me relief of this problem.
We will try to help you as much as possible, sir. Sir, may I ask you some personal questions if you don't?
Yeah, please carry on.
Sir, may I ask you what is your occupation?
I am a carpenter by occupation.
Sir, you live alone at home or with somebody?
I live alone.
Okay. Sir, do you smoke?
Yes,
Sir, how many cigarettes per day?
5 packs per day.
Okay. Do you take a drink? Do you take alcohol?
Yes,
Can you tell me how much units per week or how much?
5 units.
Okay. Sir, do you is any of your family member have a similar complaints? Your father or your mother?
No, no, doctor.
Okay, sir. Sir, before I go further, could I ask you, do you want to add something which I missed in the history?
Nothing, doctor.
Good.
Okay.
Can you summarize your history now? Can you present your history now?
A 54-year-old male presented with a progressive difficulty in swallowing, initially to the solid, then to the liquid, with a significant weight loss. My provisional diagnosis, my differential diagnosis will be carcinoma esophagus, as the
Yes.
patient has a history of smoking as well as alcohol intake.
Okay. What
And second
investigation?
differential,
Yes, please go ahead.
and second differential will be heart gastroesophageal reflux disease.
Okay, good. All right. And the third one could be the carcinoma, etc. All right. What investigations would you ask for this patient to confirm your diagnosis?
I will To confirm my diagnosis, I will need a blood investigation in the form of complete blood count, blood urea nitrogen, and urine culture and sensitivity. Along with the, I will go for a barium swallow and CT scan.
All right. What are the management options that you can offer to this patient?
After getting the investigation, I will discuss the case in the multidisciplinary board.
Good.
And if it turned out to be a carcinoma esophagus, and it is not a local, it is a localized disease, I will try to give a cure to the, I will try to give a definitive treatment in the form of esophagectomy along with radiotherapy. And if it is an advanced disease on the scans and all, and then I will go for a palliative procedure, like in the form of medicines, chemotherapy, radiotherapy, and stunting.
Good. Feeding due to masculine infection. All right, still 9 seconds left. Good. So can you give the feedback? It was good, both of you. You covered, managed to cover everything.
Ma'am, can I ask one question?
Yes, please. Yes, please.
I just want to ask, ma'am, is the summary sufficient? Because every time we will provide a long summary. This time I tried to provide just a short summary for 30 seconds only.
Yes.
Is this
it
sufficient?
It was sufficient. But then once you summarize, then you should have stopped there. And you should have allowed me to ask you, so what are your differential diagnoses?
Sorry.
Instead, yeah, for next time, I'm just saying,
So,
instead you just went on and asked,
yes.
told me, and then you just stopped there. Once you are telling the differential diagnosis, then at least 3 you should tell, 3 to 4. So that
Okay.
is the take home message. And in the beginning, where I felt that you were like in a hurry kind of thing, your questions that you asked your patient were not formed enough, like they were not well thought, despite the fact you had the vocabulary, enough vocabulary you have, because you said how it initiated.
Basically, I was concerned about the time, I think so, ma'am. He was concerned about time.
That's why
he finished in. He finished
within
That's
the
what
time.
What I felt is, yeah, as I am also preparing for the exams.
Yeah.
We are mainly focused upon the
timer.
What is your concern? What do you think was supposed to do, and what do you think the cause is? We are concerned about this, so we will be in a hurry to reach these 3 questions.
Yes.
Yeah, I totally agree, Dr. Bichau. I was trying to cover up this in the given time, because I felt like the bell will just run.
So basically, you have got like 4 weeks time. So within these 4 weeks on continuous rehearsals, we'll come to know subconsciously when we have to approach to these 3 questions.
Yes.
Okay. Yeah. When we started the station of dysphagia, we have to go in an order. Like what happened is, you have to first initially ask with the onset, progression, duration, how is the course of the disease, what are the aggravating factors, what are the relieving factors. This is the main part of dysphagia. We are supposed to be confined to this dysphagia first. Then only our differentials has to come into the play. Okay, so what happened in what we practice is, we have asked about the onset and the duration. Then we jump into the differential diagnosis of lump in the throat. Then again we came back to dysphagia.
Yes. So that's why.
So whatever station it is, whatever the station would be, let us finish the given complaint. So once we first finish the given complaint, then we can ask about the differentials. The problem is, once we interrupt the patient in a otherwise, what we call, we'll ask the patient to speak. Apparently, what I have learned from our seniors, we'll ask the patient to speak. So we can't ask the patient to multiple times about the same dysphagia again and again. To take the proper history of dysphagia, leave the dysphagia aside, then you focus on differentials. And after you confine, right? You break down the differentials, like pharynx, esophagus, stomach. These 3 things are the main anatomical parts related to dysphagia. So initially you have asked for lump in the throat or swelling in the throat. So thyroid, it has been evaluated. Then regarding the pharyngeal pouch, what you have done is, you have asked for gurgling. Okay, you have then you have asked for bad taste. Then again, you went back in the end of the differentials, again focused on pharyngeal pouch. So once we keep the pharyngeal pouch in mind, we have to finish that then and there itself. We are not supposed to again about it, ask about it again. Okay. Then one more thing is regarding the esophagus, we have to ask about CA esophagus has been done, and you are focused about the neurological disease also, and you are focused about the GI. So everything has been asked. We have to list a bit systematic way. That's it.
Good. Nice
I am
explanation.
started
Very good.
studying. That's why I am telling you. Sorry.
No. I totally agree, Dr. Vichau. Thank you for that.
Yeah.
But I just actually I try to wind up in the given time. This is
Yeah,
my
yes, but
main
this
goal,
thing
because
happens. This thing happens. Tend to happen.
because
And why? Because
last time when we do the history part, we always has a issue with the summary also. We try to elaborate too much, and it will take almost this time. My aim is to provide just 30 seconds to the summary, because then the question will follow about around the summary.
bro, summary.
Which is
Summary. What you have done is proper, brother.
It was enough.
There is
Yes.
no way bothered about summary. We are only bothered about how we are taking the history. Like many of my friends who have cleared, like all of them have been the participants of MAM's group only. So their history was not finished. They were not focused on history. They were focused only on how we are talking to the patient, whether we are patient enough to listen what patient is telling to us. Okay, so most of them who have cleared, none
totally
of the
agree.
stations have been completely finished. None of their clinical examination is finished. So, but they passed. It's like, so what they're telling you, they will judge you how you are behaving with the patient. Now we going in a systematic way. Even you are lagging behind, they're not going to scrutinize you much on that. So HOPI, as you all know, the basic thing, then followed by past history. Now what we have done is we have done HOPI. We went back to eye symptoms. I mean the concern and the cause. Then again we came back to past history and personal history. So eventually we'll develop this rhythm. So I don't think anything else is missing. Only the systematic way we need to focus on. That's it.
Yes. Thank you.
Thank you. Yes, and here is your question, please. Right, so if you have read and understood, considering its surgical anatomy station, kindly identify what are you looking at? The image?
It is the dorsum of left hand.
Okay, good. Yes. All right. Can you please, in the picture, left picture, there is this tendon. If you can identify.
Number 3.
Yes. This is the tendon. If you can identify which one is it?
Extensor digitorum.
Which one? Extensor digitorum. Okay. All right. Can you identify 16 over here, please?
It is extensor retinoplum.
Extensor retinoplum. Can you please tell me the attachment of extensor retinoplum, please?
It is attached to the medially to the pisiform and hook of the hamate, and laterally with the lower end of radius.
Okay, what are the structures which pass below it? If you can tell me from
Madam,
medial
there is
to lateral or lateral
six
to medial.
compartment.
Yes, very good. And
From lateral to medial, there is extensor carpi radialis longus and brevis, extensor carpi ulnaris, extensor digiti minimi, extensor pollicis longus, then abductor pollicis longus and extensor pollicis brevis and extensor pollicis longus.
Good. Okay, if you can come on to the right hand side image or picture, there is this space has a particular name. Can you identify this place or space?
Anatomical snuff box.
Yes, please. Can you
Anatomical
tell me the
snuff
yes,
box.
please. Good. Can you tell me, please, the boundaries of an anatomical snuff box?
Madam, laterally abductor pollicis longus and extensor pollicis brevis and medial extensor pollicis longus.
Good. And what is the floor is formed by, and what are the contents of an anatomical snuff?
Floor is formed by the content is the radial artery. Radial
Yes.
artery is the content, and
In
floor is maybe the scaphoid bone.
scaphoid bone. Good. Okay. A person doing skiing slips and falls with outstretched hand, and later on complains with complains with the pain in the anatomical snuff box. So what are your suspicions? On examination, clinical examination, you don't find anything. So what would you suspect?
Maybe he was suffering from fracture scaphoid bone.
Good. Okay, what is the scaphoid bone? There is a characteristic. It takes its blood supply from where, and which part of scaphoid bone is more liable to or vulnerable to avascular necrosis?
Madam, scaphoid bone got his blood supply from the distal side, so proximal part is susceptible to avascular necrosis.
Right. So how should this patient be managed? What should we do?
Ma'am, we should do an X-ray of this patient to
Okay.
find out is there any fracture, and we should immobilize the wrist by
Yes. For how long?
thumb spica
Yes. Good.
for from 3 to 4 weeks.
Okay. Can you please tell me
And-
all the movements which are possible at the thumb joint?
Flexion, extension, abduction, adduction, opposition.
Good. What are the muscles which are responsible
Circumflexion.
for the opposition movement of the thumb? Yes. Three muscles.
Opponent's pollicis.
Yes. And two others?
Flexor pollicis brevis.
Brevis and abductor pollicis brevis. Good. Which nerve supplies these muscles?
Abductor pollicis brevis.
Which nerve supplies these muscles?
Madam,
Median.
median nerve.
Median nerve. Good. Okay. Can you please, if you are looking at picture A, can you please identify and tell me 16? Wait, where is this? So this is 16. If you can identify 16, please.
It's the radial nerve. Sorry, ma'am, median nerve.
Median nerve. Good. Can you tell me
Median.
the sensory distribution of the median nerve in the hand?
Ma'am, 3.5 lateral 3.5 of the palmar side, and the tip of the dorsum of the thumb, index, and middle finger.
Good. And the motor distribution of the median nerve in the hand?
Median nerve supply the thinner muscle and fasten to second lumbrical muscle.
Very good. Okay, this another structure I want you to identify. It's 25.
25. This is the ulnar nerve.
Very good. Can you please tell me if there is, okay, when is it called ulnar paradox? Injury of the ulnar nerve is called ulnar paradox when? In which condition?
When ulnar nerve is injured in the elbow joint, there
Yes.
is a paralysis of the muscle of the hand, and along with the flexor carpi ulnaris and medial half of the flexor digitorum profundus. So the clawing of the hand is less visible.
Pronounced.
So
Yes.
this is called less pronounced, and so this is called the ulnar paradox.
Very
And
good.
ulnar claw hand is more pronounced when ulnar nerve is injured in the wrist joint.
Very good. Okay.
At the
Moving
region.
on to the left image, sorry, right image. You can see something, it's 30. Can you identify this, please?
It is the radial artery.
Radial artery, very good.
Mm.
And 31 over here, please.
31 mm ulnar artery.
Very good. Right. And then there is 27 as well.
27 is ulnar nerve.
Looks like a muscle or something.
So,
Okay. And then there is this one more, if you can identify 29. Sorry, this 29 over here. So this is coming and it's going like this. If you can identify
this is the
superficial palmar.
deep.
This one is superficial.
Superficial
Deep one
palmar.
will be 11. See, it's deep. If you look closely, so this is superficial. And what is this 27? Yes, Dr. Beecher or Dr. Kuldeep, anyone else want to identify?
Is that
and tell us?
radial? It is an artery, ma'am.
I'm asking right now.
It is radial,
radial.
and 30th is superficial branch of the radial artery. 27th is radial artery, and 30th is superficial branch of radial artery that completes the palmar arch by the ulnar artery.
This I would have to confirm because it doesn't, it
Yes,
looks like a vein to me because it's more purple, or it's a muscle. Because this is artery. So
Yeah, that
31
is a superficial branch of ulnar artery, ma'am.
and
That forms
27
the
is more
palmar.
darker. So I was thinking it's vein, but
Okay.
I don't know. I have to check the atlas. Okay. Yeah, we can radial artery. So, and here is your question.
Ma'am, these are the questions to be given in the exam also.
Yes, similar. But these are my questions. They'll have what written in these traditional notes. Okay. So if you have read and understood, considering your surgical pathology session, kindly tell me what are your differential diagnoses after reading this scan?
Ma'am, my most probable difference in diagnosis would be it can be a rheumatic fever.
Good. And
Or it can be mainly or heart pulmonary pathology
okay. Or
like COPD or
yes.
asthma, or it can be infective endocarditis, or
Okay.
it can be connective tissue disorders.
Yes. Or valvular condition. Okay. Can you please tell me what is the, if you'll consider that it is rheumatic heart disease, how would you, yes, how would you, what is the criteria that you consider? Or how would you confirm your diagnosis? How would you
Yes, ma'am.
differentiate
First,
between,
I
yes,
will differentiate between what, ma'am?
rheumatic heart disease and infective endocarditis?
Yes, ma'am. For rheumatic heart disease, we will follow a criteria called Jones criteria, whereas
Yes.
for infective endocarditis, we'll follow a criteria called Duke's criteria.
Good.
In Duke's criteria, will involve mainly major and minor criteria. In that, to sustain a patient for the diagnosis of infective endocarditis, it has to be 2 major or 1 major plus 3 minor or 5 minor criteria. In the major criteria, it can be of mainly of echocardiac findings, or it can be of blood culture findings. In minor criteria, it can be of vascular phenomena, or it can be immunological phenomena, or it can be recent history of fever, or any other criteria which are not fitting in the major criteria. Likewise, for revised Jones criteria for rheumatic heart disease, in this will involve mainly
Okay,
major criteria like
that
involvement
is not needed. Can you please tell me how would you define the term infective endocarditis?
Infective endocarditis is defined as the inflammation of the endocardial surfaces of the heart, including the valves and the endocardium.
Of the endocardium, yes. What are the types of infective endocarditis that you are familiar with?
It can be subacute infective endocarditis, or it can be limb sac endocarditis, or it can be a merantic endocarditis.
Yes.
Subacute infective endocarditis because of bloodstream infection.
Yes.
Whereas limb sac and merantic are usually occurring in a malignancy.
Okay, can you please tell me what are the causes that lead to the condition infective endocarditis?
Conditions leading to infective endocarditis. One is it can be a valvular heart disease of the heart, or it can be a valve replacement which has been done, or it can be previous rheumatic heart fever or previous infective endocarditis itself, or it can be structural or functional diseases of the heart which are congenital like cyanotic or acyanotic heart diseases, but well repaired AST has been excluded. And apart from this, if a patient is having other immunosuppressive conditions like diabetes, hypertension, or HIV, or any other malignancies, they are
Good.
susceptible for developing infective endocarditis.
So what are
Previous
the
tooth
risks? Yes, very
infections.
good. What are the risk factors for infective endocarditis that you should watch out for?
Now, one is oral surgery involving the main tooth surgeries.
Yes.
Other is any immunosuppressed conditions. Patient is
Yes.
on any steroids, or is any other malignancies. Then old age, followed
Okay.
old age, and comorbid conditions
Yes, and valvular
like
replacement,
diabetes, hypertension,
etc. So
and valvular replacement surgery.
if you don't get to manage this condition on time, what are the complications that you should expect to occur?
If we don't get to manage in time, it can be mainly lead to infective endocarditis. These things it can be divided into a cardiac and non-cardiac
Very good.
things.
Yes.
If
Yes.
it's a cardiac is getting involved, mainly the valve will be getting abnormal. So valve regurgitation can be there. Because of that, it can be volume overload can be there. Because of that, it can lead to congestive cardiac failure, and it can lead to arrhythmias, and it can lead to emboli and valve vegetation formation. Non-cardiac is these emboli can get dislodged into the brain. They can lead to stroke, or they can go into the kidney, forming acute kidney injury or glomerular nephritis, or they can dislodge into the intestine, causing mesenteric infarct or splenic abscess.
How does it differ when a native valve is involved or when a prosthetic valve is involved when it comes to organism which is found?
Ma'am, these valves basically there won't be blood vessel. These organisms lie inside the valves, and for which there won't be blood circulation will be adequately passing through these valves. And
Yes,
even
there is
the
a difference in,
antibiotics which has been given won't be
organisms.
functioning.
There are difference in organism which affects the native valves and which affects the prosthetic valves. Which organisms affect the native valves?
Okay.
And which, yes, please.
For implanted valves, it is coagulase negative staph aureus is
Yes.
CONS organism will be more commonly involved for artificial valves. Whereas for native valves, it can be staph aureus or streptococcus viridans and hex a group of bacteria. Haemophilus, Salmonella, Kignilla, and Acetobacter.
Yes, and then there is also for prosthetic valves, there is also dependent. The factor is early and the late. Organisms differ because of that. So good. Okay.
Okay.
Once you know that patient has infective endocarditis, you diagnosed it and you got it confirmed. What are the management options available that you can offer to the patient?
Ma'am, first initially once patient is diagnosed with infective endocarditis, I would like to do a blood culture sensitivity to isolate the organisms, and antibiotics are to be given as per the sensitivity to the organisms. And if suppose patient is not responding for the antibiotic, then later we have to plan for a valve replacement or a heart replacement procedure.
Yes.
After conveying the necessary blood grouping and the HLA typing.
What are the restrictions that you have to focus on or you'll consider?
Restrictions, the antibiotics which we have been prescribed for the culture
Yes.
sensitivity doesn't act upon these valves, and
Yes. Why?
the organisms lie within the valves, so they are resistant for because there is a formation of biofilm around the organisms. This acts as a glycocalyx protection for the organisms, preventing the exposure to the antibiotic by a bloodstream.
Good. And these valves are bloodless. That's why. That's another reason they don't have specific blood supply. Can you define the term vegetation?
Ma'am, vegetations are these are friable due to infective endocarditis.
Okay.
Yes,
Right.
ma'am. This can lead to valvular insufficiency. Either there can be valvular regurgitation or valvular regurgitation with causing insufficiency of the valve function. I'm not sure about the definition, but that's what I made it up.
Yes, but what happens? How these vegetations can be diagnosed?
Ma'am, these vegetations can be diagnosed mainly by doing an echocardiography.
Very
On
good.
echocardiography,
will
we look
appear.
after this valve structure, and if there is any valvular insufficiency, whether there is a valve, there is velocity of the jet velocity of the blood, the length is more than 1 centimeter, or if the radius is more than 0.25 meters per second, this is the velocity has to be noted, the jet velocity. And also there will be flip-flap valves which are noted on the echocardiograph.
Yes, and there's this fish mouth appearance of the valves.
Okay, fish mouth appearance. Okay, fish mouth appearance of the valve.
Good.
Yes.
Started your timer, and here is your question. Right. So if you have read and understood, considering the critical care scenario, kindly tell me how would you manage this patient?
Manage the patient according to case protocol and assess the patient with ABCD procedure. I want to talk with the patient. If patient is talk error is clear, and I see the movement of the chest, and if it's okay, and give some oxygen to non-rebreathable marks, and I assess the circulation of the patient. I open to wide bore needle cannula and collect some blood for plasmacine and full blood from liver function test and other blood glucose and other tests, and then I so I check the patient GCS and exclude the patient to see any abnormality present or not, and then I make a catheter of the patient to monitor the urine output, then I go for investigation.
All right. Did you
Mm.
mention doing CT scan? How would you? Yes, this patient had a pulsatile abdominal mass in the left flank. So how would you confirm your diagnosis?
I will first confirm my diagnosis, first scan, ultrasonography, then I also plan for CT angiogram.
Okay, with CT. So what is the criteria if you have seen that there is abdominal aortic aneurysm? So what is the criteria for the follow-up of the aneurysm?
Okay, if ultrasonography done and we say that CT angiogram, we say that it is 3 to 4.5 centimeter, then it is small. So if you follow up the patient every yearly, anti-screening every yearly, and if there is a size is 4.5 to 5.4 centimeter, then it is a medium aneurysm, and we follow up the patient every 3 months, and if increase, we plan for surgery. And if a patient aneurysm size is more than 5.5 centimeter, then we go for surgery to prevent rupture of
Very
the
good.
aortic aneurysm.
Can you please tell me in which gender abdominal aortic aneurysm is more common and more lethal? Males, very good. Very
Male
good.
gender
Yes,
is
male. Okay, can you please tell me, yes, why is it so difficult to stop the bleeding when abdominal aortic aneurysm ruptures?
if a rupture occurs, then contraction of the vessel is losses, so it is
Yes.
difficult to stop the bleeding. Also, if we resuscitate the patient, so we give some fluid, so that is causes a hemodilation and also develops thrombocytopenia, so platelet not aggregated, and that also causes difficult to manage. And also hemodilation causes coagulation factor, unlike fibrin is reduced. For this reason, also causes difficult to form clot, that also causes difficult to manage
Very
the
good.
bleeding.
Okay, very good. Okay, can you please tell me what is aneurysm and what are the types of
Aneurysm
aneurysm which
means
are present? Yes, please.
aneurysm means a dilation of the blood vessel more than 50%. There is a different type of aneurysm, like true aneurysm, false aneurysm, pseudoaneurysm, also secular aneurysm, and infective causes
yes.
mytic aneurysm.
Very good. Can you please tell me what are the complications of abdominal aortic aneurysm?
If a abdominal aneurysm become larger, that causes difficulty in breathing, and if it's rupture, that may causes continuous bleeding, that causes multi-organ failure, and that also causes ischemia of the limb, spine, and spine, and also ischemia in the bowel. That also, if it is involved in the ascending ascending aorta, that causes MI, myocardial infarction, and it is due to arch of aorta, then causes stroke.
Very good. Okay, if just suppose you have been following up a patient and now patient needs to be operated. So what are the management options, or does not need to be operated, but what are the management options that you can offer to the patient while you're following up?
If there are two type of procedure, like endovascular procedure and open procedure. In
Very good.
endovascular procedure, we can place a graft on the vessel, and if we cannot manage it, then it will open and close into an anastomosis or grafting.
Okay, considering these surgical managements, what are the immediate post-op complications that you can expect?
Due to massive blood transfusion, hemorrhagic shock may develop, hypoglycemic shock, then
But
or
come
multi-organ
before,
failure.
before that, there could be
Okay.
endoleak, there could be, because you are putting a graft, right? So
Yes, and
endovascular,
then
what
due to
is,
graft
yes,
rejection,
rejection, or there could be
graft
endoleak,
rejection may,
or there could be, yes, ischemia of the spinal cord.
yes, and also ischemia of the limb, ischemia of the bowel,
Yeah,
also
liver,
develop,
and then there could be delayed rupture
and
of, yeah. And what are the medical
rupture of the abdominal
complications?
aortic angiogram.
What are the medical complications that can occur?
Sorry,
Acute
ma'am.
cardiac failure, acute CCF, then
Yes,
acute renal
myocardial
failure,
infection, a
yes,
stroke,
yes, yes,
renal failure, and also a stroke also, and
Good.
abdominal compartment syndrome also a complication.
Right. So can you tell me, you just touched upon hemostasis. How does, in this patient, how does this vascular surgeon interferes with the mechanism of hemostasis?
By about first, sorry, ma'am, I understand the question.
Think, you know, you already know the answer, you told me, because you told me how
Yes.
the bleeding cannot be stopped. So that is
Difficult
the
to
natural.
interfere. Okay.
Yes, but now this vascular surgeon is trying to repair the aneurysm. So how this vascular surgeon is interfering with the natural mechanism of homeostasis? What is he doing?
And vascular contraction is reduced due to resection of the vessel. Also, due to hemodilation, platelet is not aggregated, so and thrombocytopenia may also causes difficult to stop the bleeding, and also due to dilation, coagulation, fibrin also reduced. That also causes difficulty to coagulation.
Good. Okay, but then this fibrins are being formed normally, but what surgeon is doing, that surgeon is disrupting the normal environment. So it is like more, there is more fibrinolysis, so clots, if clot has to form, that will be dissolved more. So there'll be more thrombin formation, etc. So that is what surgeon is doing. Here is your question. Right. So if you have read and understood, considering this communication skills, can you begin?
Hello, I'm Dr. Mohammed, one of the surgical doctor. I'm calling to speak with Mr. Mann, the vascular surgeon, to ask him an advice about a patient. May I confirm who I'm speaking to, please?
Yes,
Okay.
please summarize your case.
Okay, I'm calling from downtown hospital. I'm working with Mr. John. I have a patient who is female, 54 years old female, has been admitted with mild diverticulitis, and her symptoms show improvement after taking fluid and antibiotic. Now the problem is she has complaint of sudden onset of acute severe lower limb pain. On examinations, an investigation showed there is metabolic acidosis with hypokalemia, and also we did a duplex scan. It showed that she has acute limb ischemia. Also, we did show that complaint of atrial fibrillation and broad periventricular complex. I'm calling to transfer this patient to your specialty care. Is that okay?
Is it urgent? Can you send it tomorrow morning instead?
So I'm fear that this is urgently. So the patient needs urgent interventions because this is acute limb ischemia. So there is a fear of loss of limb.
Okay. Do you need cardiologist to review before transfer?
Actually, she need the cardiologist after the transfer, as this is the most urgent thing here is acute limb ischemia.
Okay. What do you think of a presumed diagnosis of diverticulitis?
Sorry?
What do you think of a presumed diagnosis of diverticulitis?
Yes, because of ECG shows atrial fibrillation and the patient's complaint of acute limb ischemia, I would suspect that the cause of abdominal pain is mesenteric ischemia.
Okay, so would you like to do any scan for the abdomen first?
Okay, I will do the CT abdomen and pelvis, but after the transfer the patients.
Okay.
And also if the renal profile is okay, I will do CT with contrast.
Whether it is now mesenteric ischemia?
Yes, I will do duplex scan for the mesenteric vessels.
Okay. What if the renal functions are not normal?
Then I will go for magnetic resonance arteriography, or I can also do the duplex scan.
Okay. How could manage this case?
Okay, first I will treat the atrial fibrillation. I will call the cardiologist. Then I will manage the metabolic acidosis. Also, I will give her anticoagulant.
Okay. How about the AF? How would you like to manage?
Sorry?
How do you like to manage atrial fibrillation?
Yes, I will arrange with the ICU doctor. I will ask for cardioversion and also for anticoagulant.
Okay. What type of ambulance will you need?
I will ask for well equipment ambulance with cardiopulmonary resuscitation equipment with oxygenation, and also ambulances contain the cardioversion.
Okay. What type of anticoagulant you will give?
I will start with infraction heparin, 5,000 international units. Then I will give her 15 international units per kg per hour. And so then I will monitor her using ABTT until between 40 and 60 seconds.
Okay. How about the ischemia limb?
For the ischemia, yes, if the limb is viable, then I will go for some paralysis or inflectomy or arterial bypass with or without fasciotomy. If the limb is not viable, then I will go for amputation.
Okay. What will you tell her family?
I will tell that there is acute reduction in blood circulation in the limb and this need urgent intervention so that we are transferring the patient to the vascular unit, which is not available in our hospital.
Okay. Who will accompany the patient?
I will accompany the patient. Also, a nurse will accompany.
All right. You can send over the patient.
You still have
Okay,
2
thank
minutes.
you. Can we summarize what we have been
Yes.
through?
Yes.
Yeah, please.
Yes. For the patient, my plan of management, I will manage her metabolic acidosis, and also I will give her anticoagulant. And also I will manage the atrial fibrillation. I will arrange with the ICU doctors for cardioversion and anticoagulant. For the mesenteric ischemia, if the renal profile is okay, then I will go for CT with contrast after transfer the patient. Then I will speak with the relatives.
Okay.
Thank you.
Yes. Do you think metabolic acidosis could be because of acute lung injury? Do you think?
Yes, it can
metabolic
be.
acidosis because of the multiple acidosis and metabolic acidosis.
Yes. Then how do you, if it is because of ALI, how do you plan to manage then?
We'll give sodium bicarb.
How acute lung injuries are supposed to be managed?
Acute lung injury. I will manage using secret protocol.
Yes.
I will secure the airway and breathing. I will give high flow oxygen via an under-breathing mask, 50 liters. Then I will do just X-ray and ECG.
Okay. How a vascular bypass is done?
Vascular bypass. I don't know what this.
We were just finishing off the time. Okay, good. You people just finished it in 6 minutes.